Bismillahirrahmanirrahim. Today we shall talk about hemodynamics. You will notice that with my name there is a Dr. Taha Ahmed. He's one of your Yemeni colleagues. وهو الحقيقة he helped me to collect a lot of the tracings that we are going to see. And that is why I put his name on also, because he did the hard work for the talk here. The talk will be divided into the following, the certain definitions that you need to know. You should learn the cardiac cycle by heart because it helps you in your clinical work. And then we go to the Cath Lab. And what we do in the Cath Lab, and then the normal pressures and tracings that we will see. And then calculations like shunts, resistance, and how much is the shunt. When we say this is an ASD with a shunt of 3:1, so what do we mean by that? And the resistance of the pulmonary vascular resistance is the most important. And then examples of different diseases. Probably next time I sit with you. الكونفرنس هيبتدي الثلاثة الجاي ولا اللي بعديه؟ Okay. The definitions that we need to know are hemodynamics. What is hemodynamics? It is a study of the forces involved in circulating blood through the body. Hemo, blood. Dynamics, movement. Or it is relating to the physical aspects of blood circulation. The same. Okay? The forces involved with the movement of blood throughout the human circulatory system include kinetic and potential energy provided by the cardiac pump, gravity, hydrostatic pressures, and pressure gradients or differences between any 2 points. These are what govern the flow of blood. So when we say in a patient with Fontan, there is no pump. We have lost the pump function to push the venous blood to the lung. Therefore, the blood has to depend on the pressure gradient between the peripheral veins and the pulmonary circulation. Okay? And that gradient has to be sustained, because if it's disturbed, the patient goes into heart failure, into congestion, severe venous congestion. And truly enough, these patients develop liver cirrhosis with time because of the high venous pressure that they need to sustain the circulation. Properties of blood itself that affect its flow, the blood itself, viscosity, the inertial mass, and the volume of blood to be moved. Okay? Factors that affect the motion of blood through the vascular conduits, like the arteries and arterioles and the venules, include site of the blood vessel. Is it the aorta or the capillary? Condition of the blood vessel. Is it stenosed with a plaque in the coronary artery? Smoothness of the lumen of the blood vessel. Elasticity of the muscular layer, which is the tunica media, and the destination of the blood, the distal vascular bed. Is it a normal vascular bed or a disturbed vascular bed? These are all what we need to know as regards. The physical concepts have definitions. These are the blood concepts, the hemodynamic concepts. Now the physical concepts. We need to know certain definitions like pressure, flow rate, and viscosity. So pressure is the ratio of a force acting on a surface to the area of that surface. Okay? So, for example, why is a camel's foot wide, and when he puts it in the sand it even gets more, so that he can walk in the sand, right? A horse, for example, will sink more into the sand than a camel, but that's why the camel is made to live in the desert. Okay, that's the reason. Same with a lot of other animals, like the elephant has a huge, is very heavy, and of course we don't want him to sink into the mud, which is where he usually lives, around muddy areas and stuff like that, and he loves to play in the mud and stuff. So because he's so heavy, he needs a big surface area so that, so this force is the pressure. The flow rate amount of fluid passing a given point over a given period of time. Cardiac output is the simplest. Okay, 5 liters per minute. Viscosity, the internal friction between adjacent layers of fluid, not necessarily blood, any fluid, but we are talking here about the plasma and the blood. So when there is a very viscous blood, many RBCs, it becomes more viscous, difficult to move, and can even clot. Okay? Blood is 1.5 times as viscous as water. Keep that in mind. The cardiac cycle is extremely important because it defines your idea in space of when valves open, when they close, and forming the sounds, the different sounds, and so on. So when you know that the opening snap occurs with the opening of the mitral valve, then you know that it is after the second sound, because that's when the mitral valve opens. There is an isovolumic relaxation phase when all the valves are closed until pressures change, and then the mitral valves open. So if the mitral valve is moderately stenosed or mildly stenosed, it will make a sound when it opens because of the sail effect, and that sound is the opening snap. So when you know when the mitral valve opens, then you know that this is an opening snap. Same with an ejection click, aortic and pulmonary clicks. There is an isovolumic contraction phase where all the valves are closed until pressures change, and then the 2 semilunar valves open. So you can get an aortic click after the first sound and a pulmonary click after the pulmonary sound, after the second sound. First. Okay? So that's, things like that are very important. Always remember that electrical events occur first, followed by mechanical events. So the P wave in the ECG comes first before atrial contraction, just before it. All right? Always. And you know from your physiology that there is a rapid filling phase and a slow filling phase, and so on and so forth. So it's very important that you learn everything you need to know in the cardiac cycle related to the electrocardiogram, which is your timer. That's why we do not do hemodynamics except if there is an electrocardiogram, supposedly. We don't see that all the time, but it should be there, because this is how you time your opening, the ventricular pressure, what occurs, as you can see in the systole. The systole occurs from the beginning of the QRS to the beginning of the T wave, end of the T wave, that's systole. Or although the T wave is a diastolic event, but the mechanical systole is from the QRS to the end of the T wave. And then diastole goes on, and then atrial contraction, as you know. So this is an example of what I need to know. You need to take this picture and know it by heart. It's just another one of the same, but maybe they put more sounds, the first sound, the second sound, the third sound, and so on. So it helps you there. The third sound is physiological in young people because of the rapid circulation, and so that happens like in teenagers and sometimes even in children and so on. Now we go to the Cath Lab. What do we do in the Cath Lab? If people have watched us while we were working, you know that we take pressures. We're supposed to take oxygen, but it's such a tedious thing to do because we don't have an oximeter in the Cath Lab. We have to take the oxygen, bring it here to the ICU, do the tests, and then wait for the results so I can know what to do next, which is ridiculous. Okay? We used to have a colorimetric oximeter in the Cath Lab, which had little plastic things. You fill it with the blood, and you just put it in, and it gives you, from the color of the blood, it gives you the oxygen saturation immediately. That was much easier. I tried looking for one. They don't sell them anymore because, as you know, cardiac catheterization now is not an important means of diagnosis in heart disease as much as it is now an interventional thing. The only thing that we do cardiac cath for diagnosis is pulmonary hypertension. You want to prove that patient has pulmonary hypertension and the resistance is high, for example. This is the time when you need to do a cardiac cath. Or if you have a very big discrepancy between your clinical and your investigations, your imaging, there's a big discrepancy, you need to do a cardiac cath, okay? Otherwise, catheterization mostly interventional right now. Because why? Why we don't need to diagnose by catheter? What's happened to the world today that makes the catheter not necessary? Echo? Echo, contrast echo, TE echo, all these echoes, strain rate, all that stuff, plus MRI and CT can give you even function. MRI can give you function, can give you flow rate, can give you cardiac output, can give you all kinds of things, even shunt, all right? So what we do is pressure measurement, oximetry, CO, cardiac output calculation, shunt calculation, and resistance calculation, or should I say, we used to do that. What's the preload of a ventricle? That's the filling pressure that goes into the ventricle. So it's the chamber before, all right? So the preload of the right ventricle is the mean central venous pressure, or right atrial pressure, which is between 2 and 8 millimeters mercury, all right? That's the filling pressure of the right ventricle, or preload of the right ventricle. Preload of the left ventricle is the mean left atrial pressure, or the mean pulmonary artery occlusive pressure. I will tell you what that is now, or pulmonary artery and diastolic pressure. All these are the filling pressures of the left ventricle, or preload of the left ventricle. And the pulmonary artery occlusive pressure, it is sort of like a wedge pressure. It is 8 to 12 millimeters mercury. The pulmonary artery diastolic pressure is 10 to 15 millimeters mercury, approximately, okay? So the 10 to 15 is more or less within the 8 to 12, or maybe the 15 is a bit higher as an end diastolic pressure for the pulmonary. So if we translate this to a patient with Fontaine, again, who has no pump on the right side, you always want his pulmonary artery pressure or occlusive pressure, end diastolic pressure of the pulmonary, the end diastolic pressure of the left ventricle, of the left atrial pressure, all these, the pulmonary venous pressure, to be in that range, so that the circulation from the veins can go to the left side without much trouble. The afterload of the right ventricle, what is the afterload of a ventricle? It is the resistance of the distal place. So pulmonary vascular resistance is the afterload of the right ventricle. Systemic vascular resistance is the afterload of the left ventricle. It's indirectly assessed as the pulmonary vascular resistance, and the normal pulmonary vascular resistance is 1.5 to 2.5 Wood units. If you multiply that by 80, you get 120 to 200 dynes centimeter to the power 5, or something silly like that, which I really don't care about. The afterload of the left ventricle, also indirectly assessed, the systemic vascular resistance is 10 to 15 Wood units. Again, if you multiply by 80, you get 800 to 1200 dynes. All right? So you can tell how much the systemic vascular resistance is compared to the pulmonary. So if you have a normal 1.5 to 2.5, let's say 2, and you have 10 to 15, let's say 12, so that's about 6 to 7 times more than the pulmonary. The systemic is 6 to 7 times more than the pulmonary resistance. All right? Now we come to a very important aspect in the Cath Lab, is how do we measure a pressure? Of course, there are electronic ways to do that, which is done usually for research. And there's the pressure measurement, which is a fluid-filled catheter passing by a transducer. What is a transducer? What does a transducer do? That occurs in everywhere in life. in people who deal with electricity, people who deal with pressures, what is a transducer? In our case, for example, it changes the pressure to an electrical signal. So it changes one form of energy to another. In this case, pressure to an electrical signal, which you see written on paper. Okay? That's the function of a transducer. So when we have a fluid-filled catheter, there is a diaphragm which we put, and we put the diaphragm at the level of the right, the right atrium, which is the central venous pressure. And this diaphragm is very sensitive to the movement of blood in the fluid-filled catheter from my pressures inside the body. The catheter is inside the body, say in the left ventricle, and then the ventricle pumps systole. So this is transferred to that very sensitive diaphragm, which transfers this signal to an electrical signal, which you see written on the monitor. That's how we measure the pressure. So fluid-filled catheters go to a manifold with a transducer. The silicon diaphragm is the sensing element. Fluid pressure is transmitted to this element through a medium gel inside the inside the transducer. Referencing the pressure to a zero is very important. So just before I take my pressures, I tell the people, please guys, give me a zero pressure. What is meant by a zero pressure? I open my fluid-filled catheter to the atmosphere. The atmosphere is and placed at the mid-right atrial position. This is my zero pressure. That's how I will measure my pressure, standardizing at that level. And then when he comes and he sees that the line of the zero is not correct, he leaves it on until it corrects itself with the atmosphere, okay? And it becomes zero. Then I can start measuring my pressure. I will get accurate pressures. Small air bubbles inside your system may damp and lower the pressure. Motion of the tip of the catheter, like a catheter whip, when you have an ASD and you have a pulmonary vascular dance, a hilar dance, this hilar dance makes the catheter move like a whip. So this adds to the pressure. It may be a lot more than is expected. So you may have a superimposed wave of 10 millimeters mercury, common in PA. Also, the catheter impact artifact, when a catheter is hit by a valve, like in the left ventricle when the mitral valve opens and the catheter hits this, the pigtail catheter is opening by the mitral valve, may hit it also and change your pressure. So we always try to put our catheter in a position which is not too close to the mitral valve and also not stuck in the apex, somewhere in between. Okay, so it's not affected by the mitral valve. The same goes with the pulmonary artery. If you go a bit further into the pulmonary circulation, so long as there's no pulmonary artery stenosis, of course, then you can get a good pressure without the whip. And this is an example of your zeroing. Okay, I started off like this. I waited until it corrected itself. And then you have a scale, the calibration. Yani if I tell him calibrate please for me to 100 millimeters mercury. So this amount is 100 millimeters mercury. So if I put the left ventricle, then 120, so it will be above the 100. Okay. If I tell him to put the 40 millimeters mercury, your left ventricle will go up into the sky because that part is only 40 millimeters and you have 120, so 3 times that to get up to. Okay. And sometimes when the left ventricle pressure is very high, like in aortic stenosis, I ask him to put the calibration on 200. Okay, so I can get my ventricle inside I can measure it properly inside this. So this from 0 to 200 is in that space. That's what is meant by calibration. And this is the zeroing point of my transducer. That's where I place it. The intersection of the fourth intercostal space and half the anteroposterior diameter of the chest. This is where we always place the transducer. On the table has a rail, and so you push the transducer on that rail, okay, until you reach that point. And up or down back, you can get in the proper place. As I said, there is two types of signals: the fluid-filled catheter signal and the electronic signal. Okay, they are quite similar, as you can see. One is more sensitive than the other. The electronic, obviously, is more sensitive than the fluid-filled catheter. But the fluid-filled catheter suffices very well for our daily work. The other one is mainly for research purposes, and it's done in labs and stuff like that, and probably on animals and things like that. This is an example of a normal pressure. Where is the, what have I done? This is an example of a normal pressure, okay? This is an example of a damped pressure. This is an example of a damped pressure. Hello. A damped pressure. If you have bubbles in your system, whether the bubble is in the catheter or in the tubings or at the manifold, all these are areas where bubbles like to stay. And so you will get a pressure like that. You say, what's going on? So you withdraw your blood and then you do a proper flush and you have fluid-filled catheter again, and this pressure changes to become a normal pressure like that. Okay. This is an under-damped pressure, which we see sometimes in very rapid circulations and things like that. And sometimes in a patient like this, I will add a little bubble. So I will change it from an under-damped to a normal pressure. At least that's what Dr. Khaled told us, and it works. Because he's the one, when we started cath, I was very early in the cath time when there was no Seldinger technique in the femoral. We used to cut down and use the brachial artery and the veins around it for the right and left catheters. So we did catheters every day for diagnosis, all the time. Congenital and valvular disease, all the time. And that's how we learned. And that's how we learned the hemodynamics and all these things that we see today, which are not that important, as you can see. Okay. It's important to know hemodynamics for your own physiology of the circulation and understanding the circulation and how the heart works. That's what I mean, why we're doing this hemodynamics. Not so you can go ahead and do caths. If you want, you can, but it's to understand. Systolic pressure amplification in the periphery. If you take a pressure in the subclavian or the aortic artery and in the femoral artery, you'll find that the femoral artery has a higher pressure. Okay? But the mean is the same. The mean in the aorta and the subclavian and the carotid and the femoral is the same. All right? And this is the example that I'm showing you here. You can see a subclavian artery, which is a central artery. And this is what? Radial artery, which is a peripheral artery. You notice the difference? The sharper rise and the higher rise and so on, but the mean is the same. And this happens as you go from central to peripheral. What are the normal pressures and tracings that you face? When we used to do a cath a long time ago for diagnosis, we used to have a drawing like this with the different diseases. So a fallot will have a drawing like this with the stenosis in the subpulmonary area and maybe the valve. Also, there will be a VSD and an overriding of the aorta, and the right ventricle will be thickened. It was a drawing that we had, actually a book that we had like this. We photocopy it, and then when we did our cath, we write the pressures and oxygen saturations on that paper and present it in the conference. Our weekly conference that you see now, we had this thing, the fanus اللي بيعرض. You know that? Yeah. Okay. And we used to do that, and that would be easy for people to see and understand. And as you can see, these are the different pressures. Some important basic knowledge to know is the A wave in the right atrium is bigger than the A wave in the left atrium. Okay? Always remember that. And of course, as you know, the pulmonary artery normally is around 25/10 systole diastole. Okay? And the right ventricle obviously is the same, but it's not 10, it's 3 to 5. It's an end diastolic, so it'll be 25/3 to 5. The left ventricle, as you know, is 120/5 to 10, or 10 to 12 if you like. And the left atrium, we usually use the mean, but the left atrium should be around 10. The mean should be around 10 a day. Okay? We should talk about them. What we do to make it easier for you, I like to, the easy way to remember the normal intracardiac pressures is a multiple of 5. It's not accurate, but it helps. So the right atrium is 5 plus minus 2. The right ventricle is 25/5 plus minus 5 plus minus 2. Pulmonary artery 25/10. Left atrium is 10 plus minus 2. That's the mean. And the left ventricle is 120/10 to 12. Okay, so that gives you an idea. If you remember the multiples of 5, you will be very close. Okay. This is a right atrial pressure taken simultaneously with a left ventricular pressure. I have no idea why they did that, but they did that. You can see your calibration. 0 here, 50 millimeters here. All right. What do you notice? If this is 50, therefore this will be 10, 20, 30, 40, 50, yeah. So this will be 10, all right? So your right atrial pressure is high, for sure. Because the right atrial pressure, usually the mean average is 5, we said. So 10 is high, okay? And then you come to the left ventricle. The end diastolic pressure in the left ventricle, as we said, is 10 to 12. You come. Where do you see the end diastolic pressure? Is with the Q wave. We don't have an ECG here, so this you cancel. This is no good for hemodynamics, so long as you don't have an ECG. When you have an ECG, the end diastolic of the left ventricle is with the Q wave of the QRS. You bring an imaginary line down from there to the pressure tracing. That is your end diastolic pressure. I am sure it's high here, but because I don't have an ECG, I will not be able to tell. But it will be here, around here, about this area, okay? And this is around 20, or maybe more, 25. So it's a high pressure, all right? But this is the fault with this tracing, is that there's no ECG. There's the ECG, now you can see. Very clearly seen. Normal pressure tracings of the right atrium, which is this one. A normal pressure tracing of the right ventricle, which is this one. As you know, the normal pressure tracing in the right ventricle, obviously, if it's normal, then it should be around 25, maximum 30. So the calibration here is slow. Okay, this is a normal pressure tracing of the pulmonary artery. That's how it looks. And this is a normal pressure of the pulmonary capillary wedge pressure. What is a pulmonary capillary wedge pressure? How do we do that? What do we do to get a capillary wedge pressure? What kind of catheter? One is a balloon, but that's an occlusive pressure, not the pressure. That's the pulmonary artery occlusive pressure. With a balloon, you go into a peripheral artery and you open the balloon, so you have no pressure after that except deflected from the left atrium, okay? But a wedge pressure is you actually wedge your catheter in the distal pulmonary artery. You wedge it where it cannot go anymore. How do you know you're wedged? You come to draw blood, it does not get blood. So you're wedged. That's a wedge pressure. And you have to do it with a catheter which has no side holes. It has to be an end hole catheter, which we don't have anymore. Okay? Because you need the end hole to wedge it properly and get a proper reflection from the left edge. If you have side holes, it's going to be mixed, not the proper pressure. ECG, as you see, a ventricle. Probably the left ventricle because it's at 100, it's systolic, or a right ventricle in a patient with pulmonary stenosis, but it's probably more of a left ventricle from the shape. Okay? So if you come to measure where the end diastolic pressure is, you go from the Q wave down, 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 down. Here, this is your end diastolic pressure. You actually you get a ruler and you put it straight from the Q wave down to the pressure tracing. That is your end diastolic pressure. Always remember that. This is a pressure tracing of arterial, of a great one of the great arteries. Okay? If your calibration is high, like 100, this can be an aortic pressure. If it's low, like 40, this could be the pulmonary artery. This is what we call by peak measurement of pressure. Okay? You know that when we measure, we have a peak measurement. When we come to say, for example, a pressure gradient, it is peak to peak. Peak ventricle to peak artery, whether the aorta or the pulmonary. That's the pressure gradient, if there is a pressure gradient. And here is your end diastolic pressure. It's not a very good line because he's actually at the downslope of the QRS. He's supposed to be at the Q wave or at the tip, maximum, no more than that, or at the tip of the R. Otherwise, it's not accurate. So this is a bit out of... Okay, how do we calculate shunts? We use the Fick principle. Do you remember the Fick principle? Is, for example, a certain amount of dye is injected into a peripheral vein. For example, okay, you want to see how quickly it reaches the pulmonary artery. This is done by a machine. All right. So this is what we call the thermodilution method, the dye dilution method of measuring the cardiac output. You can use temperature by injecting ice-cold saline into a peripheral vein, and then they see there is a catheter which checks, a thermistor catheter, which checks the temperature in the pulmonary artery. So you can easily know how much the blood has flown in that amount of time. Okay, and the temperature change that occurred will give you the calculation of the cardiac output on a machine. It just calculates it. Okay. إنما the proper way of doing the cardiac output زمان بقى, it was very tedious, very tedious. We have to have the patient come and we do a respiratory test عشان نشوف the maximum oxygen consumption and a whole bunch of things so that we can get the cardiac output. طبعا now the MRI gives you the diastolic volume and the systolic volume. You take them away from each other. You have the stroke volume times the heart rate gives you the cardiac output. Very simple. So there are many Cath labs in the world now that are hybrid. A hybrid Cath lab with an MRI machine. So the patient is on the same table, he's on, and the table goes from the MRI to the Cath lab. He checks for his cardiac output in the MRI and then goes to the Cath lab so he can finish doing his cath. It may be an intervention, most probably. Okay. طبعا these are expensive machines. To have a hybrid Cath lab is very expensive. You have an MRI for several millions, you have a Cath lab for several million. طبعا that's a lot of money for countries like ours. Not easy. Okay. Now we want to calculate the blood flow using oximetric data. pulmonary blood flow, you know that flow equals, what do we say, resistance, flow equals pressure over resistance, right? Remind me, guys, remind me. The equation for flow and pressure and resistance معروف قوي بس أنا طبعا مش cardiac output equals pressure over resistance, right? Yeah, pressure over resistance. This is the basic concept of Fick principle, okay? Anyway, pulmonary flow equals oxygen consumption over the difference in pressure between the pulmonary venous oxygen and the pulmonary artery oxygen, which is the pulmonary circulation. So the pulmonary flow equals the amount of blood crossing the lungs divided by the difference in oxygen between the vein and the artery, right? The same with the systemic. Systemic flow is the oxygen consumption divided by the oxygen between the aorta and the mixed venous, which is the superior vena cava, right? Okay, so QP to QS is the first equation, this equation divided by this equation, right? So you can تقلبيهم يبقى you remove the oxygen consumption on both sides, you are left with aortic oxygen saturation minus mixed venous, or I should say aortic minus superior vena cava over pulmonary vein minus pulmonary artery. Let's take an example in our head. The aorta, say, is 100, just for, it's 99, doesn't matter, 100. And the mixed venous is 70. This take away, that is 30. Okay? The pulmonary venous oxygen is 100 minus the pulmonary artery is 70. Right? So there is no shunt. All right. Let's take an example of a shunt. Aorta is 100. The mixed venous is 70. So that's 30. The pulmonary vein is 100, but the pulmonary artery is 90. So that's 10. So that's 30 over 10. That's 1 to 3. So you have a pulmonary flow to aortic flow of 3 to 1. Shunt of 3 to 1. Pulmonary to aortic. Okay? That is the whole concept of shunt calculation. So you need an oximetry if you want to calculate a shunt. Now the MRI does it, even the echo can help a great deal in calculating. So you don't really need to do Cath Lab for diagnosis. Before the echo, we started Cath before the echo. And then when the echo came, it was only M mode for a number of years. And so we really had to do the thing in the Cath Lab. ASD patients, VSD patients, babies, we did because there was no Cath Lab in the pediatric. They had no pediatric cardiology department yet. So we used to do 2 months and 3 month old babies up here. I used to do them with Dr. Khaled. He taught me because he spent a lot of time in pediatric cardiology in the States. So he came back and he taught us the congenital and the concept and the cath and all that. Here's an example. I shouldn't have written the bottom part, but I did that to make it easier for you, but you could have calculated it yourself. Aorta minus mixed venous. Where is the aorta here? 98. The mixed venous is the superior vena cava, 71. How much is that? 27. Okay. And then you have the pulmonary vein. Where is the pulmonary? 99. Pulmonary artery, 90. So 9. So 27 over 9 is 3 to 1. It's the same as the example I gave you with a bit of difference. So this is the shunt. This is QP flow in the pulmonary to flow in the systemic circulation is 3 to 1. Q stands for flow, and P stands for pressure, and R stands for resistance. So Q flow pulmonary to flow systemic is 3 to 1 in this example. It may be 2 to 1. If it's less than 1.5 to 1 at the atrial shunt at the atrial level, and the right ventricle and right atrium are not enlarged, you can leave the patient and do follow-up. You treat him like a PFO. Although that 1.5 shunt is not small, with time probably the ventricle will enlarge. Resistance calculation is a bit more, there is the equation. Flow is pressure over resistance, okay? So cardiac output is the differential in pressure or the pressure gradient على the resistance, okay? So therefore the resistance becomes اعكسيها بقى الريزيستنس التحتاني ده هتطلعيه هيبقى البريشر على الفلو. So therefore resistance equals pressure over flow. We know that the systemic vascular resistance is 10 to 15 units. Pulmonary vascular resistance is 0.25 to 1.6 Wood units. And the Wood units equal millimeter mercury minute per liter. Multiply by 80, you get dynes seconds per centimeter to the power 5. حاجات كده هبلة في الماث بقى احنا ملناش دعوة بيها. The vascular resistance بقى you calculate will be زي ما قلنا resistance equals pressure over flow. فيبقى systemic vascular resistance mean aortic pressure minus mean right atrial pressure على cardiac output. Pulmonary vascular resistance is equal mean pulmonary artery pressure minus mean pulmonary capillary wedge pressure over the cardiac output. You know the cardiac output is stroke volume times heart rate. So therefore it is end diastolic volume minus end systolic volume, which is the stroke volume, times heart rate. With a hybrid Cath Lab, it becomes easily attainable with an MRI. Okay? You don't need to do طبعا. It's always better to do your things at the same time. يعني مش معقولة we send the patient to an MRI in Heliopolis, yes, and then after 5 days we do the cath. There is no use in that. The cardiac output would have changed, the resistance would have changed, a lot of things would have changed. Okay? So that is why the hybrid Cath Lab, so you can do it immediately. Cardiac output, as I said, the Fick principle. So it is Adolf Fick in 1870 who described this principle, where the oxygen consumption equals flow times the arterial oxygen content minus the cardiac output times the venous oxygen content, mixed venous blood oxygen content. Okay? So therefore Q will become the oxygen consumption minus over the arterial oxygen content minus the venous oxygen content. Do you think it's easy, this oxygen content? No. Saturation is something, content is something totally different. Saturation is what we do with the column, saturate the thing saturated in the Cath Lab, which gives me the saturation. I can work with it. And oxygen content equals hemoglobin, which is grams per deciliter, say 15, times 1.34, which is what you call it, a constant, times percent saturations, plus another constant, times ppm, a whole big equation. Okay, that will give you the oxygen content. We don't need to know these things. Don't worry about it. You won't be asked about it because, believe me, the professors don't even remember any of those things. Combination of age plus they haven't read it for ages. That's why I'm telling you sometimes I forget these things. Okay, so when you have the oxygen content, arterial and venous, then you can calculate the resistance when you have the cardiac output. Again, the cardiac output you can get from the MRI. Okay, you can calculate the oxygen, the content of the arterial blood and the venous blood. That will give you the resistance in whichever circulation you want, pulmonary circulation or the venous circulation. Thermodilution method I was talking to you about, which is a very special catheter, which is extremely expensive because it's a catheter with 4 ports and a thermistor, something that measures temperature. And you inject cold saline into a peripheral vein, and then you take and sample from the pulmonary artery. and this is it's calculated on a computer, so you don't need to do its calculations. Okay, but this is usually done in the CCU. When you have this kind of catheter, it's for the CCU for emergencies. طبعا having a Swanganz catheter in the CCU is extremely important because it helps you in treatment, right? You need to know, is the capillary wedge pressure high or low? If the patient is shocked, what kind of shock is it? You see what I mean? It's very important to have a Swanganz catheter in the CCU, which I don't think we have. And by the way, it is done in the CCU. You don't need to go to the Cath Lab to put a Swanganz catheter because it has a balloon, so it floats. So you put it in your inferior vena cava and the femoral vein, مثلا, or jugular. Jugular is better, and you go into the superior vena cava and you inflate the balloon. It will flow into the right atrium, right ventricle, and pulmonary artery. You take down the balloon, all right? You push it into the pulmonary artery, you inflate the balloon, you get the wedge pressure. You deflate the balloon, you have the pulmonary artery pressure. So it's a good way to know what you're dealing with and how to treat, what kind of drugs to give and so on. You need to give fluids, for example. You might just need to give fluids. A patient may be hypovolemic and needs blood or fluids. Okay? Here is a patient where we've done a progression of the catheter from the right atrium to a pulmonary artery occlusion position. So this is the right atrium. The balloon went into the right ventricle. I got a right ventricular pressure. It went to the pulmonary artery. I got pulmonary artery pressure. I inflated the balloon. I closed the pulmonary artery, so I get a wedge pressure. All right? What do you notice about the mean wedge and the pulmonary diastolic? They are the same. If you want to know whether your pressures are correct or not, you do the end diastolic pressure in the pulmonary artery. It should be the same as the mean wedge pressure, unless the patient has pulmonary hypertension, core pulmonale, arterial hypertension. مش venous hypertension. If it's venous hypertension, يبقى the wedge will reflect to the pulmonary artery, the mean will be the same. But if it's a pulmonary arterial hypertension, like congenital heart disease مثلا, or core pulmonale, you'll find that the wedge is normal, but pressure is high. Okay? That's another way to differentiate between diseases also in the ICU. I know that this is a lot of information. The محاضرة هنا موجودة. Okay, examples of different abnormalities, I can do that on another time. All right? وبشكركم ويعني I'm disappointed انه مش اكتر من كده موجودين لانه once هيجي لكم في الامتحان يا اما هيموداينامكس يا اما انجيو. اوكي؟ وطبعا انتوا عشان كورونري ما بتشوفوش غير كورونري انجيوز. You don't see ventricular angios, you don't see VSDs, you don't see anything of that sort. Or pulmovalvular stenosis. I haven't يعني هل مثلا بيعملوا انجيوز تشوفوا aortic stenosis او pulmonary stenosis؟ مفيش. لازم تشوفوها هنا معانا. يا اما تحضروا معانا في الكاث لاب which is difficult يعني مش معقول هتسيبوا شغلكم وتيجوا الكاث لاب عشان تشوفوا. So we see these things here. And they probably will have one of those times a congenital angio of some sort, whether it be Fallot or pulmonary stenosis or even an intervention, a balloon in the pulmonary artery, where really like a pulmonary artery being ballooned. يعني كل ده ممكن يجي as a tracing. But you should know these things. تمام؟ الثلاث الجاي اخباره ايه؟ عندك فكرة؟ What's next Tuesday؟ النهارده كام؟ 10 يبقى 17